Hi, everybody, and welcome to this webinar on addressing behavioral health disparities through state policy. I'm Sean Sloan. I'm a senior policy analyst at the Council of State Governments in Lexington, Kentucky. Here is a look at our agenda. I'm going to provide a quick overview of the Mental Health Matters Task Force, which the webinar is an offshoot of sorts. Then we will welcome this great lineup of presenters. First, we will hear from the data experts, Nirmita Panchal, who is a senior policy analyst at KFF, formerly known as Kaiser Family Foundation, and Karen Stam, who is director of the Center for Workforce Studies at the American Psychological Association. Next, we'll hear from our friend Debbie Plotnick, who is Executive Vice President for State and Federal Advocacy and Mental Health America. And finally, we'll turn to our state policymakers, including Representative Deanne Vaught of Arkansas, as well as other legislators and legislative staff joining us today. If you have questions for any of our presenters, you may type them into the Q&A here on Zoom, and we will ask as many as time allows at the end of the program. We encourage you to use the chat function as well to share resources and connect with others on the webinar. But first, just a bit about the Mental Health Matters National Task Force on Workforce Mental Health Policy. This is an initiative created as part of the U.S. Department of Labor's State Exchange on Employment and Disability. It was convened by CSG and the National Conference of State Legislatures. The task force was co-chaired by Senator Becky Massey of Tennessee and Colorado Lieutenant Governor Diane Primavera. In addition, we had 31 other state policymakers and 8 subject matter experts participate. The group met twice in person and twice online. We had 4 subcommittees of the task force focused on such issues as non-discrimination, parity, and benefits, workplace care and supports, underserved rural, racial, and ethnic communities, and behavioral health workforce shortages and state resource systems. The work of those subcommittees is reflected in a policy framework published this summer by our friends at NCSL. And I believe my colleague Paula can share the link to the framework in the chat for everyone to check that out. So the underserved rural, racial, and ethnic communities subcommittee was the one where behavioral health disparities were addressed perhaps most directly. Among the policy principles identified, examine the accessibility of effective mental and behavioral health continuums of care, including wraparound services for under-resourced communities, identify sustainable funding for mental and behavioral health services, and ways to reduce silos and create more entry points into mental health services. Establish incentives and options for preventive care to mitigate further needs and reduce costs over time, as well as address long-term funding and sustainability of preventive care. Create and strengthen community and stakeholder engagement by ensuring underrepresented communities are involved in councils, task forces, or agencies to reinforce equity, transparency, and ongoing collaboration. Establish and implement a system to measure, evaluate, and continuously improve community mental and behavioral health outcomes, and determine ways to recruit and retain mental health professionals from under-resourced communities to reflect the communities they serve, such as by developing a pipeline for these workers, especially those serving in outpatient settings. The full framework, as I said, is available for your reading pleasure at that URL. And there are additional resources coming soon, both from CSG and NCSL. We will also have a session focused on the task force's work this December at the CSG National Conference in Raleigh, North Carolina. And I'll have more to say about that at the end of the program today. Right now, I want to welcome Nirmita Panchal. She is a senior policy analyst for KFF's program on the Affordable Care Act and the program on Medicaid and the uninsured. Her work focuses on research and data analysis for mental health and substance use. She's going to talk about what the data tells us about mental health and substance use in communities of color. Thanks so much for joining us.
Hi, thank you so much for having me. As Sean mentioned, my name is Nirmita Panchal, and I'm a senior policy analyst at KFF, where most of my work focuses on mental health and substance use disorder policy research. So today I'm here to talk with you all specifically about mental health and substance use research that we have been doing among communities of color and the disparities that we have been seeing as well. So as you may know, in recent years, many people of color have experienced worsening mental health outcomes, in addition to access to care. And during the COVID-19 pandemic, the data has shown us that people of color have also been disproportionately impacted in multiple ways, which may be affecting their mental health. So to get started with this presentation, I will focus on how drug overdose death rates are disproportionately affecting communities of color, as we have seen particularly in the last few years. Next slide, please. Great, thank you. So as we know, drug overdose deaths have surged in recent years, and the preliminary data from 2022 shows that the highest number of drug overdose deaths were recorded in that year. And the primary driver behind these deaths is opioids, particularly synthetic fentanyl. And so what we see here in this slide is the change over a 10-year period, going from 2011 to 2021 in drug overdose death rates, looking across racial and ethnic groups. And while these death rates have increased across all racial and ethnic groups, many people of color have been disproportionately affected. Black and American Indian and Alaska Native communities now have the highest death rates across all populations. And further, these death rates in general are growing fastest among communities of color. Next slide, please. So in this slide, this is another way to look at how drug overdose deaths are impacting communities of color. So here we're looking based on the population distribution. And what you'll see is in the first two bars on the left of this slide, we see the distribution of drug overdose deaths by race and ethnicity in 2011, and then next in 2021. And notably, we see that while white people continue to account for the largest share of drug overdose deaths overall, this share has decreased over time from 83% in 2011 to 67% in 2021. Meanwhile, the share for people of color accounting for these deaths has increased. Further, what this slide demonstrates is how the distribution in drug overdose deaths compares to the total US population distribution by race and ethnicity, as you see in the last slide all the way on the right, last bar, sorry. When we compare the last two bars, we can see that although Black people make up approximately 13% of the US population, they now account for 18% of drug overdose deaths, further highlighting emerging disparities among communities of color. Next slide, please. So shifting gears a bit here, what you'll see on this slide is that suicide deaths have also increased over time, both nationally and across all racial and ethnic groups. And in this slide, we're looking at data once again from 2011 to 2021. And what we see here is that the suicide death rates among American Indian and Alaska Native populations have increased sharply over the decade. Their suicide death rate now far outpaces the death rate of their white counterparts, for example. Further, although Black and Hispanic suicide death rates remain smaller than their white peers, their death rates among these communities of color has grown faster within the decade. Next slide, please. So when we look at data on mental illness and substance use disorder, we do not see the same degree of differences by race and ethnicity as we saw specifically with suicide and drug overdose deaths. So, for example, similar shares of white, Black, and Hispanic people have reported having a past year substance use disorder or mental illness in 2021, seen in this slide. However, as you can see, American Indian or Alaska Native people have the highest prevalence of past year substance use disorder and mental illness compared to other racial and ethnic groups. So why is it that we see these larger differences in other outcomes, such as suicide and drug overdose deaths, as I shared previously, across racial and ethnic groups, but not with mental illness and substance use disorder? Well, there are a number of reasons, and the research primarily points to the underdiagnosis of mental health concerns among people of color compared to their white peers. Next slide, please. So, for example, some of the factors contributing to underdiagnosis may include the lack of culturally sensitive screening tools that would allow better detection of mental illness among people of color. Another contributing factor could be certain structural barriers. And moreover, symptoms of mental illness or substance use disorder among people of color might be labeled as disruptive or criminal compared to their white counterparts. This practice can occur in childhood, where behaviors that may be characterized as a mental health concern among white children are considered disruptive and penalized among children of color, and could therefore encourage underreporting of mental health issues among these children. This labeling, in turn, can result in a disproportionate number of Black people, for example, being diverted into the justice system instead of mental health treatment centers. Next slide, please. In our research, we also found increased barriers to accessing mental health and substance use treatment among people of color. Several structural inequities may contribute to the disparities in this use of mental health care. For example, the lack of health insurance coverage or financial and logistical barriers. Other factors can include the lack of a diverse mental health workforce and the absence of culturally informed treatment options. For example, in our research, we found that although Hispanic and Black people accounted for 30% of the US population, they only made up 9% of the psychology workforce as of 2015. This may be a barrier to treatment access and retention, as we've also learned that racial and ethnic concordance among patients and providers can play a significant role in patients having positive experiences with their healthcare providers. Stereotypes, discrimination, and stigma associated with poor mental health are also factors among some communities of color. Black adults may view mental health conditions as signs of personal weakness and worry about discrimination and experiencing shame in acknowledging their mental health concerns. And also, as I've discussed earlier, drug overdose deaths have disproportionately affected communities of color. Now, one of the approved treatments for opioid use disorder is buprenorphine, but in our prior research, we have found that compared to white people, Black and Hispanic people have limited access to buprenorphine. And in general, the uptake of medication-assisted treatment services has also remained low among other communities of color, for example, American Indian and Alaska Native people. And finally, for this slide, these barriers to care may have also worsened in light of the pandemic. Next slide, please. So as we see in this slide, among adults with mental illness, smaller shares of people of color receive mental health treatment compared to their white counterparts. For example, you'll see here that 52% of white adults with any mental illness reported receiving mental health treatment in the past year, whereas 25% of Asian adults with any mental illness reported receiving mental health treatment in the past year. And I also want to note that other racial and ethnic groups are not included in this slide because there was insufficient data. Next slide, please. It's also important to note that many children of color are experiencing negative mental health and substance use outcomes. Drug overdose deaths among adolescents have remained relatively stable for years. Yet during the pandemic, these deaths significantly increased, and these increases were largest among Black and Hispanic youth compared to all other racial and ethnic youth groups. American Indian and Alaska Native adolescents also have the highest suicide death rate compared to their peers. They are 3 times as likely to die by suicide compared to white adolescents. And the suicide death rate among Black youth is also quickly increasing. Firearm death rates have also sharply increased among Black and Hispanic youth in recent years. And these increases among these communities were primarily driven by both gun assaults and suicides by firearm. Next slide, please. In recent years, several changes have been made in accessing opioid use disorder treatment, which is something to consider as we look ahead with the ongoing epidemic of not only substance use issues, but also other mental health issues. So as I was saying, some changes have been made in access to opioid use treatment. And one of these changes includes increasing the number of prescribers to treat opioid use disorder. However, at the same time, it's important to consider that prior research has shown that increasing opioid use disorder treatment prescribers might not necessarily address these other long-standing issues of inequitable access to treatment across racial and ethnic groups. So, for example, earlier when I mentioned that some communities of color don't have equal access to buprenorphine compared to their white peers. Further, compared to their white peers, many people of color have experienced higher rates of COVID-19 infection and death and greater financial challenges, including difficulty paying household bills during the pandemic, which can also impact mental health. Black and Asian people have also reported negative mental health impacts due to heightened anti-Black and anti-Asian racism and violence during the pandemic. And in a recent KFF survey, we also found that among adults, looking across adults collectively, those with the greatest mental health needs, even with insurance, reported that their health insurance coverage was lacking, and they reported at times foregoing needed mental health care. So recognizing the impacts of access to care, racism, discrimination, and other impacts on mental health could play an important role in developing culturally informed care and improving access for communities of color. Next slide, please. So here I've listed some resources to our mental health products available at kff.org. If you go to our main mental health page, as listed at the top, we have a lot of different analyses looking at mental health and substance use outcomes across racial and ethnic groups, also at the state level. And if you have any questions, also, please feel free to reach out to me. And I believe my contact information is on the next slide. Yep. All right. So thank you so much for the opportunity to present. And again, if you have any questions, please feel free to reach out.
Nirmita, thank you so much. And just a reminder, if you have a question for one of our speakers this afternoon, you may type it into the Q&A at any time. We also want to encourage our speakers to take a peek in there when you aren't presenting and then respond to any questions that can be responded to quickly. And as I said, we encourage all of our participants to connect and share additional resources throughout the webinar as well. Dr. Karen Stam is also with us today. She is director of the Center for Workforce Studies at the American Psychological Association. She was one of our subject matter experts on the Mental Health Matters Task Force. She's going to talk about the demographics of the psychology workforce and the cultural responsiveness of those individuals. Karen, thank you for joining us as well.
Well, thank you. I'm delighted to be here this afternoon, chatting with all you. Next slide, please. As Sean mentioned, I work at the American Psychological Association, so most of my research focuses on national trends for psychologists. So not everything that I mentioned today will necessarily apply to the behavioral health workforce overall or at the state level, but I think many aspects do, because a lot of us face a lot of the same challenges, just in different flavors. And our first speaker set us up quite nicely for looking at some of the demographics of the US psychology workforce that we've been tracking for many years. You can see that the workforce is predominantly women. It's changed a little bit over time, but has been very largely women. The average age is about 48.9 years, and that has actually been going down in the last couple of years. And we have a lot of work to do in terms of looking at the race and ethnicity of our workforce, which at the moment is vastly white. These data are from 2021. We had about 81% white. And this slide shows some of the specific breakdowns with smaller marginalized communities. Now, if you're interested in some of the trends or the demographic combinations of, let's say you were looking at race and ethnicity and gender together, I think there's some important trends where we see a slow trend towards greater racial representation in the workforce, but it is happening slowly. So we have a lot of work to look at that. You can use this interactive data tool, which is up on our website, and we will hopefully get 2022 data up there within the next couple of months, so that those trends will be available. Next slide, please. We also look at trends in psychology degrees awarded. And what you see on this slide is the percent of individuals from minoritized racial and ethnic groups who have earned psychology degrees, because this is one of the ways that we can track some of the major entry points into the field of psychology. We also have the yellow line, which shows the percent minoritized individuals in the US population. So there's both, again, here some good news and some bad news. Overall, we're doing pretty good at the bachelor's level for psychology degree awardees, where we're actually above the racial representation of the US population. And all of these lines do show increases over time. A lot of this is being driven by increases in degrees earned by Hispanic individuals. But we certainly have some work to do at the master's level and more work to do at the doctorate level as well. Next slide, please. Now, my team has traditionally focused at our starting point for our workforce analysis at people earning bachelor's degrees in psychology. But we've had a lot of attention recently at looking at community college pathways. And I think this is a potential opportunity to strengthen some of the existing pathways by creating bridge programs or pathway programs to try to encourage some people who might be interested in pursuing additional levels of education, but might not necessarily know about the opportunities or have some barriers or financial considerations that stop them from going forward. We looked at the percentage of psychology degree holders who attended community college or have an associate's degree. And then we looked at people who eventually earned different levels of psychology degrees. And we were really surprised that the percentage of bachelor's and master's degree holders in psychology who had attended community college was about 50%, about half. And about 20% at the bachelor's level and 18% at the master's degree level actually held an associate's degree. So again, I think there's some pathways there that could be strengthened, shored up by incentives to encourage people to consider behavioral health careers beyond that. We do see a drop pretty precipitously at the doctorate level, where only about a third, 31% of psychology doctorate and professional degree holders, which is typically the level you have to reach of your education to become licensed and to become part of the behavioral health workforce, much lower in terms of attending community college, as well as earning an associate's degree. Only about 9% of psychology doctorate holders have an associate's degree as well. And these patterns are not unique to psychology. This happens in a lot of other fields. In fact, I've seen recently some similar work on social work, specifically using the exact same survey cycle and year as we did to look at bachelor's and master's degree holders in social work, which showed very similar patterns. So this is an example where there's other behavioral health professions that could be benefited by strengthening some of these pathways. Next slide, please. I would be remiss if I didn't talk about some of the counteracting forces that could affect the pathways into the field that could actually work to decrease enrollment and decrease interest in entry to the pathway in light of some of the efforts that might exist to increase those educational pathways. One of the big ones is the recent Supreme Court decision of ending affirmative action, which in the higher ed landscape has a lot of considerations about what is that going to do to the diversity of our students. And there's a lot of concerns that it will reduce the diversity of enrolled students going forward. I think we're going to see some innovative strategies from specific institutions and state level policies that might try to work within the confines of that decision to still try to maintain a diverse entry points and attract diverse individuals into certain career pathways. It's going to be a bit more difficult. So I think we need to be looking critically at what might be happening there. There's also a higher ed enrollment cliff that is projected to start showing up in the next year or two in about 2025 or 2026, which isn't all that far away. And that's largely due to a drop in the birth rate that happened during the 2008 Great Recession. And those people are now approaching college age, and there were just fewer students moving up through pathways that will eventually result in fewer students enrolling in higher ed. This is already happening at certain types of institutions. So I think we all need to be looking carefully at what might be happening in terms of decreases or potential decreases in enrollment. I think in psychology, we're lucky so far, we haven't seen any evidence of this happening yet. There's still strong interest in people pursuing psychology backgrounds, which is encouraging, but I don't think that that assumption will hold into the future, and we are certainly monitoring this trend very carefully. There's also been scrutiny on diversity initiatives that run everything from programs and places and organizations that are adding diversity offices and diversity initiatives to some places where those initiatives are being eliminated or being looked at very, very critically and are being scaled back. And that might certainly be something to consider when we're looking at diversifying our workforce. And finally, questions about the value of higher ed in general are a key thing that come up over and over again. One way to look at that is the return on investment. Is it worth people's time and energy and effort and money? Does it pay off in terms of the salaries? So that's one perspective, but also just general questions about, does higher ed impart value to, does it teach skills like critical thinking and civic engagement, and does it better the people who go through higher ed? Personally, I'm biased. I think it has a lot of value, but you know, I know there's different viewpoints there, and many other factors that I think we have to be looking at. In some cases, we hope to increase the pathways into behavioral health professions, but there's a lot of factors that just even maintaining what we have now is going to be extra challenging into the future. Next slide, please. So now we talked a little bit about the possibility of strengthening career pathways. I think one of the other perspectives that we have to consider is, what do we know about the current workforce? And what do we need to be doing in terms of retaining the workforce we already have, working with the workforce we already have to make sure they are prepared appropriately to respond to increased population health needs and health needs that are becoming more diverse over time. I think some of those, just in terms of the potential impact, the impact is actually greater at looking at retention efforts on the workforce. So this is some of our survey data that we looked at a few years ago, where we asked psychologists, how knowledgeable are you about working with 26 different population groups? And what does your frequency of your patient caseload look like for each of these population groups? There's 26 of them, so it was too hard to put all the labels, but I put all of the age groups and all of the racial and ethnic groups labeled on this graph. We were really impressed by this clear upward pattern, this correlational pattern, where in populations where the cultural responsiveness ratings or the knowledge ratings were high, the frequency of the patient caseload was high. And for populations where the caseload was low, the cultural responsiveness ratings and those knowledge ratings were also low. So this is a correlational pattern and should be treated with a little bit of caution. There's probably lots of other factors that could help to explain these findings, but it was very consistent across all of these 26 population groups. And it suggests that there are some populations that were doing a good job of treating some of the population health needs, like white populations and 3 different adult categories. But there also suggests there's some areas that might have some gaps that were already mentioned earlier today, like some of our indigenous populations, children and adolescents, where we just simply don't have the workforce in the size or the appropriate training to respond to all of those population health needs. Now, we've also done in some of our earlier work some splitting up and separating out of our workforce by career stage. And that's actually showing some very encouraging signs, similar to what we've seen in the slow changes in the demographics. When we look at psychologists who are earlier in their careers, it actually turns out that they are in general more knowledgeable about working with many of these population groups that are on the screen right now, including many of the racial groups and some of the disability groups that are not specifically labeled. So that's an encouraging sign that the new entrants or the newer cohorts to the workforce do tend to be more culturally knowledgeable. There's one notable exception for this pattern, and that's with older adults, where we see the opposite pattern. As psychologists become more advanced in their careers, they become more knowledgeable in working with older adults. And that might make sense just based on personal experience with becoming older adults themselves. So I think collectively this suggests some ways that we have some work to do, and some populations where we need to make sure we've got the workforce that has the appropriate training to respond to these population health needs. Next slide, please. So I'll wrap up today with a few food for thought items for state policy strategies that might help to improve and increase the cultural diversity and the cultural responsiveness of the behavioral health workforce, as well as some of the diversity of the workforce itself. Spent the first couple of slides talking about ways to start early and start often to increase interest in behavioral health careers by targeting community college pathways. And in many cases, the first place where students have exposure to mental health issues, partly through their own experience, but also might be through a high school course in psychology. I know the K-12 curriculum is really crowded, so it would be great if that would be earlier, but in reality, the high school psychology course might be another place to start strengthening these pathways to make people be aware of careers in behavioral health, and hopefully start to get that interest starting at an earlier stage. And it's also really important to look at our efforts to focus on the current workforce. These might include initiatives for continuing education, of requiring in the continuing education requirements for license renewal, some sort of cultural diversity training. I think that's helpful, but it is insufficient in and of itself, right? It isn't just if you build it, they will come. If you build it, they won't come. We've got data that show that, especially when you have a workforce that is facing shortages and increased demands. So these incentives to try to include continuing education would also have to make sure that such programming and such training is worth people's time and money when they've got lots of extra demands on their time. Another strategy might be to work with employers or organizations which might be in a position to respond to the local needs that they see, right? What do you see within your state? What do you see in the communities around you? And how might organizations and employers be able to offer some of the training to increase the cultural responsiveness of the workforce? And I think this is a good point for all of us. Encourage lifelong learning, right? To go in with a growth mindset, to realize none of us have all of the answers. We are always growing and learning, have a good dose of cultural humility, and to realize that there's always opportunities to learn more and do better. I could have spent my whole time talking about funding. So I will kind of just leave with that thought of, you know, a lot of this takes there's some financial aspects behind a lot of what we've been talking about so far today. And this can include funding for everything from education training programs, student debt repayment programs, higher reimbursements. If we value this, we need to unfortunately put some money for it. So I will stop there. Thank you so much for inviting me today, and happy to stay on and take questions later.
Karen, thank you so much. And again, please type your questions for Karen into the Q&A. We want to turn now to a voice from the advocacy community and hear about what the policy agenda might look like for addressing behavioral health disparities. Debbie Plotnick is the Executive Vice President for State and Federal Advocacy at Mental Health America. She is recognized as a national thought leader on a wide range of topics in behavioral health. She provides leadership for grassroots and legislative advocacy across the MHA affiliate network and to national legislator groups. She too was one of our subject matter experts on the Mental Health Matters Task Force. Debbie, thanks for joining us.
Thank you, Sean. Thank you for having me. And I am looking forward to very quickly going through a number of things that build upon the wonderful statistics that we heard from Nirmita and Karen, and talk about things that states and state legislatures, as state legislators, can be looking at that can make a difference in reducing behavioral health disparities. Next slide, please. I didn't realize we had that transition in there. Addressing behavioral health disparities, as we've heard, really begins with a more diverse workforce. And some of the ways that we can really increase the diversity of workforce is to make it more accessible and easy to get licenses and certification. Karen mentioned scholarships, loan provisions, things like that, educational ways to help people do it. Loan forgiveness is an important way too, especially for working in underserved areas and with populations where there are not a lot of practitioners. Next slide, please. I apologize. I did not realize that transition was there, so I'm sorry. I won't say it again. But I do firmly believe, and the advocacy community has been working very hard to expand the workforce in many ways. We've heard from psychology, we heard a little bit about social workers, but we really think that peers and that certified peer specialists are an incredible key to expanding the workforce and expanding diversity. Certified peer specialists are people with lived experience of a mental health condition and or a substance use condition who work in the communities and serve communities and very often look like the communities that they serve. So they are not counselors. They are supporters. They connect people. They help them get what they need. They help them articulate what it is that they want. They spend a lot of time with individuals, more so than perhaps some other professionals might get to, in helping people put up all the supports that they need in their life. Next slide, please. So I want to talk a little bit about parity, because parity is one of the most important things states can do, is to make sure that we have access. Why does access matter? Parity is so complicated that, in fact, for NCSL tomorrow, I'm doing a whole big presentation on it. I'm not going to get into the weeds. But one of the things I want to say to state legislators and staffers who are on here, it's really important to look at your state's parity laws. There's been some wonderful federal initiatives that have happened lately that have closed a lot of loopholes that make a difference, but having access to coverage is really, really important. Next slide, please. And the advocacy community has some recommendations to help states assure that their parity laws cover things that will really make a difference to people. And this is based on a model called the Ramstead model. And I have a slide with resources. You'll be able to come into this, that a number of groups, including psychiatric and American Psychological, where Karen is from, endorse having these types of things, that all coverage in insurance plans, be that in private insurance, in ERISA plans, in Medicaid, should use generally accepted standards of care. And that's an important thing. Again, I'm not going to get too into the weeds for those NQTLs that insurance companies have to watch out for, the non-quantitative treatment limits. And that means that medical necessity, when insurance, no matter what kind of insurance, must follow these accepted standards of care and not be based on just acuity, not just based on somebody's in crisis, we got to get them out of crisis, there, we're done, we wash our hands. Nope, we have to have a full continuum of care. And people often have recurring issues or need ongoing supports, but we can't just treat everything as if it was acute. We have to prohibit plans from rescinding authorization after services have been rendered. That happens to people where they've had their services, they've talked to their psychologist, psychiatrist, they've had inpatient, they've had outpatient, and all of a sudden, insurance company is not going to pay for it. There need to be real penalties with teeth. Think of that doggy, for ghost networks. And what ghost networks are is where individuals have their in-network providers in the information from their insurance plans, but they're not really there. They're not accepting new clients. They're not really in practice anymore. They might be, you'll see a lot of different names, but it's really only one provider and it changes constantly. It's very, very difficult. And it's a huge problem in behavioral health that you think you have choices, but you don't. And another really important thing, and this is something that came up repeatedly in the just closed federal regulations that were put out for comment. Lots and lots of people commented on this. So important to pay for out-of-network care at an in-network rate when the providers are unavailable, when you hit those ghost networks. So that's just some recommendations with respect to parity. Next slide, please, Sean. Thank you. I want to talk about removing some of those disparities through telehealth, which was one of the things that really expanded through the COVID pandemic and has been with us. It has helped people be able to connect with providers that look like them. It gives them more access and it gives them more time to be able to get to people, especially in rural areas where travel might be really difficult. Next slide, please. But what we really need for telehealth is on that next slide. So some of the things that can make a huge difference is making the expanded rules that were under the public health emergency permanent in each state. Some states have already done so, but we also have to have adequate broadband. This is so important. Access to communities that might not have access in their home, helping them get it in rural areas where it's not there, and expanding licensing for telehealth across states. This includes joining and creating licensing compacts. There's a wonderful psychology licensing compact and social work licensing compact. I also referenced in the references a terrific bill from Colorado that a member of our task force now Senator Michael Sinjine put forth that helps people get telehealth across those state lines, irrespective of compacts. We also really want telehealth to be reimbursed on par with in-person visits so that providers are not disincentivized to provide telehealth, and we have these availabilities still open. Next slide, please. So one of the things that's really important in terms of equity and diversity is looking at our crisis systems. And we're at a crossroads, and 988 is really a game changer. Now, we don't want people to go into crisis. Crisis is not a win. Unfortunately, that's where our attention has been focused. Like, we're not paying attention to people until they hit a crisis point. But crisis services is where we really can hone in on a great deal of discrimination and lack of diversity. Next slide, please. So crisis really matters to diverse populations because 988 does, in the just calling that 3-digit line, have some special population lines for veterans who feel more comfortable talking to veterans, another thing about peers, and LGBTQ people, again, a specialized line. And as we build out the system, and I talk more about that in a minute, it's really important for people to speak to people who answer the call in their own communities. And again, having the opportunity to look, to have people who understand the cultural needs of people who would be calling. And also people who are familiar with the services in the community, because most crises can be handled telephonically, almost 90%, but people then sometimes need to go somewhere, and the where somewhere to go and the who, if somebody needs to come out, is so important. Mobile crisis is one of those things that really makes a difference to serving diverse populations. When mobile crisis and not uniformed police, and I'm a big fan of police and a big fan of crisis intervention teams, but people feel much more comfortable when it's someone who is a clinician and a peer coming out. And then having somewhere to go. A crisis receiving center is a place that's different than a busy emergency room, or worse yet, jails and prisons, where a lot of folks are taken to the local jail, and that's not okay. There's some great examples in Arizona and Utah for looking at crisis receiving centers and continuum of care. I also want to point out warm lines. When people need more support, warm lines are often staffed by certified peer specialists and have more time for people to connect and to reconnect. But I want to go back to just one thing. We heard some statistics, and I'm not big on statistics, so I'm here. I'm more about the actions. but why it's so important to get police out of this. There's a wonderful study in the Washington Post that showed by looking through all of the states that Black citizens were 5 times more likely to be arrested. And this is crisis, this is during crisis, than white citizens, and LGBTQ plus individuals were 2.25 times more likely. So these are things to keep in mind as we look at building out systems in the states. Next slide, please. I just wanted to close with this because I mentioned CIT International, not closed, but this subject section from Ron Bruno, who is the head of CIT International, that we have to challenge the belief that mental health crisis services must come in a police car. So that's why it's so important to our discussion of diversity. Next slide. So I mentioned building out that crisis system. I'm going to pick up on something that Karen said, funding. And how do we get there? We need to assure that there's funding for 988 services, that crisis, but it's not just that moment of crisis. It's that full continuum of care that really matters. Many states are increasing their state budgets to fund the systems and build them out and make connections. And many other states have 988 small fees that they're attaching to mobile crisis bills. And I just want to point out that 911 took a number of years to get going, and it is funded by a not tiny fee, sometimes $1, sometimes $2, sometimes as much as $4 a month on people's phone bills. So it is not an alien concept, and many states are stepping into doing that. Next slide, please. Thank you. So I have a list of resources. The American Psychiatric Association has a wonderful model bill for parity. As does, I mentioned the Ramstead model that is based, has all of the things that I mentioned in there, as does American psychiatric model legislation. In terms of what states are doing and who's funding what, how, the Reimagine Crisis Coalition has that information on the website. Mental Health America is a member of that coalition, among others. And there's several state telehealth laws and reimbursement policies that are really very good to take a look at. So I put that on there. And next slide, please. I think that's my contact information, our contact at Mental Health America, and mine. Please feel free to reach out. And thank you.
Debbie, thank you. And we want to turn now to the state policymakers and legislative staff who are joining us this afternoon. And apologies if you tuned in today hoping to see Senator Maddie Hunter of Illinois. Her schedule today was such that we couldn't quite make the timing work for her to join us. We also tried reaching out to Senator Laura Fine, and we may have someone from her office on the call this afternoon. But I know there are other folks from Illinois as well, and I think Representative Lindsay LaPointe is one of those folks. But we wanted to include Illinois in this discussion because the state passed legislation this year that will require certain health professionals to complete at least 1 hour of cultural competency training as a condition for licensure. That new law will supplement an earlier initiative to provide scholarships and loan repayment programs to incentivize diverse providers to relocate to underserved communities. Do we have anybody from Illinois who wants to speak to what's going on in that state? And you can raise your hand and I will try to unmute you if yes. All right. Okay. I think, Lindsay, you need to unmute yourself. I'm sorry, I can't do it on my end for some reason. There we go.
Okay.
Yes, we can hear you.
Okay, great. Thanks so much, Sean. Hi, everybody. Lindsay LaPointe from Chicago, Illinois, chair of the Mental Health and Addiction Committee in the Illinois House. Come from a social work background myself. And just to build off kind of what you just mentioned, Sean, yes, we passed a bill here in Illinois that integrated cultural competency into our regular training for healthcare professions across the board. So that was our way to recognize that we have a healthcare system, including behavioral health, that is full of disparities, and the lack of cultural competency that providers come into with is a part of that. That's part of what you mentioned, Sean. You might have mentioned another policy. Mention it again. I can share some more on that.
The scholarships and loan repayment program, and then the cultural competency training. Those were the three things I mentioned.
Gotcha. Okay. Illinois has laid some good initial groundwork for scholarships for people going into healthcare and behavioral healthcare across the board. Obviously, scholarships in some ways hold more weight than the loan repayment on the back end, because what we need to incentivize new people to come into the workforce and to be able to stay in the workforce. Retention is a huge issue in behavioral health care. As we all know, it's a field that is endemically underpaid, especially if you're going to do the community work and work with a Medicaid population. So the more that we can widen those pathways and make this an easier career choice, the more we will have a diverse workforce that actually meets the needs of Illinoisans in this case. The challenge, though, we love to talk about challenges, is you have to fund it. And in Illinois, sometimes we pass legislation and we don't actually attach an appropriation. And so we had one program created a few years ago that we finally funded at $3 million. And that's a good start. And then we can start to build more of a track record.
Great. Thanks so much, Representative. I know that we are also joined by Representative Deanne Vaught of Arkansas, who also served on our Mental Health Matters Task Force. And she sponsored legislation in 2021 requiring the legislature to recommend policy changes to improve the state's infrastructure for mental and behavioral health services for individuals of all ages and incomes. And she can certainly speak to the interests of rural communities as well that also see disparities in behavioral health, and how Arkansas is kind of thinking about those issues. Representative Vaught, what can you tell us about what you're working on in Arkansas? Representative, are you still with us?
Can you hear me now?
Yes.
Oh, good. I couldn't figure out how to get it unmuted. Sorry.
Sorry.
So we took a giant step in Arkansas, not this past session, but the session before, and created a large working group, because silos are definitely a big issue in our state. We had different people who were offering different services, and nobody knew what each other was offering. So we brought every agency in the state that dealt with mental or behavioral health to the table. There's about 150 of us on this working group now. We continued the working group. I wrote legislation to continue on that working group this session, when we got through with this session. So we just started back last week, actually, or 2 weeks ago, working back together in our working group. There's a lot of disparities. I will say what we have found out in our state is mental health doesn't recognize income. It doesn't recognize race. It doesn't recognize social anything. We have found that, we are losing farmers to suicide. We're losing children to suicide. We're losing teachers to suicide. It is truly just a devastating I think it's a true pandemic, the mental behavioral health issues that we have going on in not just our state, but in the United States. I am a component of, I do believe things need to happen early. That is something that's the working group that I'm on in my state, is we've got to start finding these children at a much earlier age. That 0 to 3 is the perfect timing when we could start finding those children, and then continue to help them learn how to build coping mechanisms and things such as that. And that's what I have been working on. We did this past session allow pediatricians to actually start doing screening in our state, because peds are going to see them in that 0 to 3, and most would not be seen before that kindergarten age by a counselor in a school building. So we thought that would help tremendously to let our pediatric doctors start doing screenings within their buildings, and then they too can go ahead and help those people to get to the next stage. We also found out in our state that if the pediatrician can help, that more than likely there's a parent, if not 2 parents, that actually need help also, and they could be recommended to where they need to go to get help. So I think that's going to be a big deal in our state. We've thrown some funding to it. We've opened up some codes that were not opened up through Medicaid in our state, so different people could start billing that were not being able to bill prior to. We did as much as we could in Arkansas by policy, by rule making, because that's a much faster way to fix things in our state than making laws, because we're only in every other year. So we felt like anything that could be changed by a rule, we really pushed for the rule change in our state, and then came back in session and fixed it by law in policy, so that they couldn't like retroactive it and go back on what they had already told us they were going to do. So there's still a lot of work to be done in our state. That's why we'll continue this working group for the next year and a half to get policies ready for the next session. But I think we passed about 16 bills in the mental behavioral health area for the state of Arkansas this past session due to our big working group. I don't know if you had something else that you wanted me to talk about, Mr. Sean.
No, that's great. Thanks so much for sharing all that. It sounds like great work. And so we also reached out to a couple of legislators in Delaware, which this year enacted legislation to fund 988 and assess those crisis intervention services that we heard Debbie talk about. Unfortunately, both House Speaker Valerie Longhurst, who was on our task force, and Senator Nicole Poore had other commitments, but I do believe that we have Kiki Evinger, the policy director for the Senate Majority Caucus, joining us. Kiki, are you with us, and are you able to come off mute?
Yes, Sean, thank you so much. Thank you, everyone, it's a pleasure to join you this afternoon. Again, I'm Kiki Evinger. I'm the policy director for the Delaware State Senate, and I'm here on behalf of Speaker Valerie Longhurst and Senator Nicole Poore to talk a little bit about House Bill 160, which was our 988 funding bill. As was mentioned by, I think, all the speakers so far today, our advocates and our state agencies were really telling us that in behavioral health, one of the major barriers that they had to doing the work that they would really like to do is a lack of funding. And really what they were looking for was a consistent and steady source of funding that wasn't dependent on what was going on at the federal level for a state grant, or trying to get a state budget appropriation, which was challenging in our legislature over the past few years. So Speaker Longhurst and Senator Poore have been working on this issue for a while. They completed a task force in 2021 where they really looked at Delaware's behavioral health crisis system of care in a task force. We're looking for gaps, transition points, what services we had, what services we didn't. And that timing really worked out kind of beautifully with some of the movement on the federal level with the push for launching 988. We were informed by our state mental health agencies that they were really struggling to hire and retain their crisis care workers. At the time, earlier this year, when I was working on this bill, they told us they had about a 60% vacancy rate in their crisis care workers. And they were dependent on a system that if somebody called and needed assistance in the field, the operator would then have to self-dispatch, and we would lose a phone line for the undetermined period of time that it took for that crisis worker to come back from the field. Additionally, we have about 5 crisis hotline numbers advertised, which makes accessing any sort of service confusing in the best of times, but most especially when you're experiencing some sort of a behavioral health crisis. So our legislation really our goals are pretty simple. We want to make sure people experiencing a behavioral health crisis had someone to call, someone to respond, somewhere to go. And we modeled our legislation after some of the other states that had already passed. Thank you to anyone from Washington, especially, who was very helpful in answering our questions on their experience, but also mirrored our 911 surcharge. So we really leaned hard into the argument in creating a new surcharge with the parity argument that physical health and mental behavioral health should have parity and should receive the same amount of funding in the same way. So we really copied the funding structure for our E911 system, which is a 60-cent monthly surcharge on phone lines, including landlines and cell phones, and a one-time 60-cent surcharge on prepaid wireless phones. The legislation established the Behavioral Health Crisis Intervention Services Fund, which is where we are depositing all of the funding that we are collecting. It is not permitted to be used for anything else other than what is outlined in the legislation, which includes supporting 988, publicity, supporting our crisis care workers, and cannot be swept into our general fund or used by agencies for any other purpose. It also creates the Behavioral Health Crisis Services Intervention Board, which is made up of a combination of state agencies and community stakeholders who will be the ones deciding how that funding is used. Additionally, we did not want to collect a bunch of money and not really have a plan for how to use it. So while we are setting up the rules and regulations, our Department of Finances for collecting the funding, the board will be starting to meet next month to develop a plan as required in the legislation to examine how exactly to establish, operate, and maintain a behavioral health crisis center and submit a report to the Governor and General Assembly within 1 year. When the surcharge is fully implemented, I'm expecting early next year, we anticipate collecting about $9 million a year, which will solely be used for supplementing the behavioral health crisis system of care and building that out. Looking forward to attending the first board meeting next month and seeing what more we can accomplish. Thanks, Sean.
Thanks so much, Kiki. And we also reached out to several folks in Oregon, where in recent years they have been working to increase the recruitment and retention of behavioral health providers who are people of color, tribal members, or residents of rural areas of Oregon, and who can provide culturally responsive care for diverse communities. Unfortunately, all those I reached out to were otherwise occupied this afternoon, but I encourage those who are interested to look up what Oregon is doing. Finally, we reached out to folks in Connecticut, which is one of about 30 states that have passed the Counseling Interstate Compact, and one of about 40 states that have passed the SIPACT. We heard about those interstate compacts, and certainly we're big fans of those here at CSG. So the Counseling Compact authorizes professional counselors to work across state boundaries, thus providing more opportunities for patients to seek therapy and treatment, thus reducing disparities. The SIPACT, the Psychology Interjurisdictional Compact, is an interstate compact designed to facilitate the practice of telepsychology and the temporary in-person face-to-face practice of psychology across state boundaries. So encourage those who may be unfamiliar with those to look into the interstate compacts there, and you'll find more information on the CSG website. You can connect to each of those compacts. Finally, let's see. So I know that we had Senator Becky Massey on earlier. I think she may have left us, but she was one of our at-large co-chairs for the task force. Yeah, as I said, I think she may have, unless unless she wants to, if she's still on, if she could raise her hand and we can call on her. But do we have other members of the task force or other state policymakers joining us this afternoon who want to talk about things happening in their states? Or are there folks who, with questions for our earlier speakers today? We will open the floor, and please raise your hand and unmute yourself. And or again, you can type your question into the Q&A. I will call on people at random. Senator Klossmeyer from Maryland, are you with us? Can you talk about what's going on in Maryland?
Can you hear me now? Yeah.
We can. Yep.
We have several different things that are in the works. We go into session in January, and last year we passed a series of different bills. We have one that is a behavioral health study with a group, and that's progressing quite well. And just the disparities. We also had a social work, 3 bills looking at social work, and that came out of the seed group, the task force, because of the disparities in the testing and that sort of thing. So we're moving along, and I appreciate hearing everything everyone has to say. We're looking at, and I believe one of the bills that we passed last year was looking into the behavioral health in the schools. So, and I always like the Delaware plan, and so I've been working on that. So, with that, we're moving along quite well, and thanks to all the ideas that we've gotten from the task force.
Thank you so much, Senator. I think Representative Bergen from Iowa is with us as well. Can you come off mute for a second?
Thank you, Sean. I guess I just encourage people to take a look at the product that we put out from the work group with the latest studies, a number of ideas that can work in your state. Since we put this together, we haven't been in session in Iowa. That's why I'm anticipating working through our Health and Human Services Policy Committee to examine some of the products that are working in other states. But I've been really impressed personally as an opportunity to work on the project through the past few months, that there are solutions that are coming through in this report. So I just want to encourage people to pay attention to the product that has come through a collaborative effort.
Thanks for that, Representative. So question maybe for Debbie Plotnick. You know, we hear a lot about this term cultural competency, and that was one of the things that you and I talked about the other day as we were preparing for this. And your comment to me was that, you know, that may be sort of a high bar, and you know, kind of the best that folks can hope to achieve is to be humble. And you know, we heard Karen mention this idea of cultural humility as sort of a better term, and she showed us that chart with the caseload frequency and the cultural responsiveness and so forth. And we heard Nirmita talk about that recognizing the impacts that racism, discrimination, and those adverse childhood experiences have on mental health could play a role in developing culturally informed care. So what what is the level of what we can hope to achieve as states are thinking in terms of greater cultural competency or cultural responsiveness?
That's a wonderful question, Sean, and I think you use some terms that really make a difference. I think we do have to be humble. We do have to be responsive. But before we can be humble and we can be responsive, we have to be aware. And so when we think about becoming aware of people's cultural differences, that doesn't mean we have to master them, as in being competent about everybody's culture, because even within culture, there are, of course, great differences. But to just be aware of cultural perspectives, cultural sensitivities, and to be humble about it by saying upfront, please help me understand your perspective, where you're coming from, things that matter in your family and in your community.
Thanks so much, Debbie. And do we have any questions for the good of the order here? If anybody else wants to come off mute or say anything at this point. Well, not seeing any, we will go ahead and give you back part of your afternoon here. Thanks everybody for the great discussion this afternoon. Before we go, a couple of quick notes. Don't forget you can read the policy framework on the NCSL website. There will be additional resources coming soon, both from NCSL and CSG, on the issues the task force was focused on. We will also be talking about these issues during a working session at the CSG National Conference in Raleigh, North Carolina. That is set for Thursday, December 7th from 8:30 to 11:30 a.m. Eastern Standard Time. Hope you can make plans to join us in Raleigh. Registration and more information is available at the link on your screen. Again, thanks everybody for participating today. Special thank you to our presenters. Thanks to my colleagues on the SEED team, including Paula Andujar and Riley Luckfield. And thanks to our friends at Concepts Communications and the Office of Disability Employment Policy. We welcome your comments, questions, and input about this webinar and these topics. The SEED team has another webinar coming up on November 14th. Look for more information on that in the coming days. We'll look at how some states are using inclusive apprenticeships to develop the state government workforce. For now, I'm Sean Sloan at CSG headquarters in Lexington. So long, everybody.